Hello, my name is Lara Schuster Effland, and I am the Executive Clinical Director of our ERC Washington branch. I also was the founder of our mood and anxiety program in Chicago called Insight Behavioral Health Centers that we are bringing here to Seattle, Washington.
Hey, and I am Jenni Schaeffer. I'm a National Recovery Advocate with Eating Recovery Center and Insight Behavioral Health Centers as well. And I actually live in Austin, Texas, where we have both programs, which is pretty exciting for me. I'm actually going to be giving the patient perspective today. So I am not a clinician, many people ask, but I'm a patient. So we'll be talking a lot today, and I'm excited to be here. Thanks for joining us.
Hi, and I'm Andy Stone. I presented at the last webinar with Jenni, and I'm going to be mostly quiet throughout the presentation but available to answer any questions as well. And I'm the director of the Mood and Anxiety Program in Chicago.
So this leads me to, this is Lara Effland again, to kind of describe a little bit about why we feel that this topic is so important. And we're not alone in this. There's also 3 women who have been working tirelessly to really bring to those with complex trauma and high-risk behaviors an opportunity to heal their trauma and their past. And so first I want to just start with Marsha Linehan. As many of you may have already done dialectical behavior therapy, you would know her. She is the founder and the creator of dialectical behavior therapy, along with Edna Foa, who is the founder and creator of prolonged exposure therapy. And the 2 of them believed in evidence-based practices to show how we can use behavioral interventions to support an individual from the things that cause them the most suffering. So dialectical behavior therapy, that was the first section of this particular webinar that Dr. Andy Stone and Jenni did last time, and really talked about why DBT is an important asset to helping those with high levels of suffering and high sensitivity. And then prolonged exposure therapy has been an evidence-based treatment for trauma since the 1970s, and Edna Foa actually was the first to really start to begin to use it for women and sexual related traumas. And she started using that in Israel actually for the women that were in combat. And which brings us to the founder of this particular treatment that we're going to be focusing on today. And the purpose of my joining today and the purpose of this talk is for us to actually start to go deeper into what is this DBT PE protocol and how do you do it and what's advanced about it and how is it going to support our patients who are really struggling with complex trauma and high-risk behaviors. And Melanie Harned is actually one of Marsha Linehan's fellows. And what she was trying to show through her time when she first started was that there was more treatment to be done beyond stage 1 of DBT treatment. There are 4 total stages of DBT treatment, and Melanie Harned really focused her life work through 11 years of research to really develop and define what that trauma treatment is. And she wanted it to be within that behavioral scope. She wanted to continue to find an evidence-based treatment that would be in line with her principles and values of DBT. And so she asked Dr. Marsha Linehan and Dr. Edna Foa if they would be willing to go hand in hand with her and develop this protocol. And with their blessing, dialectical behavior therapy, prolonged exposure therapy protocol, DBT PE, quite a bit of a mouthful, was born. And from this, what we would like to describe in, through this hour with you today is how to really begin to assess the patient and know when they're ready to advance in starting to face those memories. So we kind of talk about trauma as being the monster under the bed, the memory in which our patients are desperately trying to avoid and get rid of. And what we're trying to do is do the opposite of that, go towards the unknown, go towards what the patient has been avoiding for so long. And so DBT PE is going to give us the protocol, the steps, to really start to do that in a way that would be effective and safe and overall going to help them face those fears to then reduce those fears. We're going to be talking about how we do this in 3 stages for DBT PE. And then we're also going to talk about all the evidence and the research that Dr. Harned and Dr. Linehan, along with Dr. Foa, have been working on to really prove and build a story and validity to this particular new protocol and why it is effective in comparison to DBT alone and prolonged exposure therapy alone, for high-risk patients especially.
Thank you, Lara. So this is Jenni again, and as you guys noticed by looking at this timeline, I've been through some struggles in my life, and I want to take a chance now just to say thank you to all that you do, because I would not be here on this webinar if it weren't for people like you who dedicate your life to helping people like me. So I want to start off by focusing on that first statement that you see there about perception of threat in eating disorders. That was actually a study with Michael Strober in 2004, but there's a lot of studies on this topic. And what Dr. Strober showed was that people with a vulnerability to having an eating disorder, like me, people who are born into this world with vulnerability to an eating disorder actually tend to have extreme fear conditioning and a greater than normal resistance to its extinction. Why is this important? Well, I think I was born into this world essentially with my fear circuitry turned up. And if you think about some of your patients, you might think about that. How many of your patients are in this world with their fear circuitry really turned up? And the second part that's important about Dr. Strober's study and the greater than normal resistance to fear extinction is that you'll see throughout our talk today that my PTSD recovery was not a straight line. And just as Laura said, my trauma was the monster under my bed. And for the longest time, it seemed like no matter what I did, nothing was working. It seemed like PTSD just wanted to hold tight in my brain. And I really do think that has to do with just my genetic vulnerability. So you might think about some of your patients in that way as well. So diving into the beginning, and we'll go through this quickly because I know some of you guys already heard my story in part 1, but birth trauma, so that obviously was the first trauma in my life. And real quickly in my life, we saw anxiety. My parents did. I'm talking about 2-3 years old. No surprise there, I'm sure, to many of you, as I'm sure many of your patients struggle with anxiety, which can lead to so many things like eating disorders and PTSD. And I'm sure you're not surprised to see OCD and perfectionism written underneath anxiety. So I struggle with those a lot too. I actually had OCD so severe that at a certain point in my life, much later on when I ended up getting help for PTSD, my PTSD therapist actually told me, Jenni, we cannot even approach PTSD until we get OCD under control. So this is just a bit of a picture of kind of why my story is somewhat complex. And perfectionism, I was definitely born with that trait. And new studies actually show, and there's some out of Australia in the recent years, that talk about perfectionism as it relates to PTSD. So if you're an eating disorder expert, you might have heard a lot about that related to eating disorders. But what we're starting to see now is that perfectionism might actually make someone more vulnerable to developing PTSD. And the study that I'm referring to out of Australia really dives into that rumination part of perfectionism. So I have that rumination part of perfectionism. Could that possibly be why I couldn't let go of that fear, why the PTSD was so strong and hard to let go of? I believe so. But so no surprise, I'm sure, to many of you to see the ED, that stands for eating disorder, developed in my life as a way to cope with anxiety and all those other things. And the important part of my story, though, is moving forward for this talk to the trauma. So my trauma actually happened 5 years into being in recovery for my eating disorder. So actually seeing really excellent treatment team and getting really good help. But I was not fully recovered when my trauma happened. I was actually in the middle of an eating disorder relapse, dissociated, depressed, and I was really in a state of just confusion. And unfortunately, my boyfriend at the time took it upon himself to rape me. And I can say that now because I've had a lot of exposure therapy. But I'll tell you what, that took me probably 10 years to say that word, and probably about that long to even realize what actually happened. And I think now it's super relevant with the Me Too campaign and all the issues going online now with sexual harassment. So I was traumatized, didn't know it. However, my eating disorder definitely popped up as the emerging PTSD symptoms started appearing, so things like startle response, depression. And gratefully for me, I actually had enough eating disorder skills, recovery skills at that point where a couple things happened where I was able to move into full recovery despite the trauma. And one important key is I actually did some EMDR. I was not diagnosed with PTSD at the time, although my therapist now says that I did have PTSD. At the time, we just chose not to use that word. But I did get EMDR, an evidence-based treatment for PTSD, very helpful. I also broke up with the boyfriend, very helpful. So I went into full eating disorder recovery. That's the good news. And the other good news at the time, I thought, was that my PTSD went away. Well, you guys are clinicians. It didn't go away. It essentially went underground. And as long as I avoided intimacy or anything remotely related to dating, then I was fine. Now, I learned much later from people like you and Lara and Dr. Stone that I was really living in a really small world. PTSD avoidance keeps your life pretty small. And if the life event that led to the arrow at the very right side of your screen, PTSD really developing, was marriage. I got married, and that eventually led to absolutely full-blown PTSD. And you'll notice that stat at the bottom, and it's just important to point out because I'm sure many of you do treat eating disorders. We often see PTSD in bulimic symptom eating disorders, and that can include anorexia nervosa, which is what I had, with binge purge symptoms. The good news in all this timeline is that even through PTSD and through the treatment, I did not relapse into binging, purging, or restricting. And so, but like I said, I developed PTSD, and there you go. That's what it looked like. You guys probably know the DSM-5, but what you might not know is some research that I just learned about. In 2011, a study came out that talked about patients with PTSD, because of what you're looking at, these symptoms, they are willing to give up 13.6 years of their life on average to make these symptoms go away. That means if Lara or Dr. Stone would have come to me when I was struggling at this point and said, hey, Jenni, we'll make all this go away if you'll give us 13.6 years of your life, I would have said, absolutely, because these symptoms to me represent a loss of self. They represent pain. I'm not going to go into specific examples. I'm sure you have that in all your clients, but what I want to point out that makes my story really complex and would have been perfect for this protocol, however, it wasn't exactly invented by the time I got help, but we'll get into that later, was I really struggled with the negative cognitions and mood, and what that meant was I became very suicidal, having thoughts, thinking about how can I actually take my life. That was terrifying to me. I became very dissociated, severely, especially in moments of rage. I remember being outside of my body watching myself yell at my husband. I thought I was going crazy. It was as if I had PTSD glasses on, and no matter what I did, no matter where I moved my head up or down, the glasses were still on, and everything looked scary. Startle responses, nightmares, avoidance, sneaking off into hotels just to get away from my home with my loving husband, because to my brain, loving husband equaled essentially a tiger, a danger. So that's PTSD from the patient perspective. And again, just so grateful we're doing this and you guys are willing to learn more about the topic. And I want to pass it off to Lara now so she can dive into more for you. So take it away, Lara.
Thanks. So for the DSM-5, one thing that I just want to go over real quickly before we move on is just the recap of just talking about the new categories for trauma and how we're looking at how one was exposed to their trauma. You can have vicarious trauma by being a witness or being inundated by the information around a traumatic event such as 9/11. Some people were not in New York. However, the ongoing coverage of 9/11 caused PTSD for individuals who were affected from afar. Also, the re-experiencing symptoms, persistent avoidance, increased arousal and reactivity, negative cognitions and mood, distress and impairment. All of these categories are going to be broken down into detail so that we can see how the PTSD has affected an individual, which has given us a lot more information and a greater assessment of whether or not someone has PTSD. There's also two different types of dissociations, depersonalization and derealization. Dissociation is going to be something that we'll talk about throughout this, a part of the protocol, because dissociation can be a behavior or a symptom of the trauma that can be an interference to the actual effectiveness of the trauma treatment. So something that we want to be aware of and continue to be assessing for as to whether or not it's happening or it's something that the patient is struggling to manage. So like I was saying before, the high-risk behaviors that we're going to be targeting for the PTSD patients that we will be treating with DBT PE are suicidal behavior, non-suicidal self-injury, severe dissociation, eating disorders, and high comorbidity of borderline personality disorder and PTSD. All of these things are very important for us to recognize because what we will look further into is the history of prolonged exposure therapy and the repeated trials that we have done to create research around the efficacy of PE treatment has actually excluded these symptoms, these categories of behaviors from their trials, which has shown over time that those that have these behaviors would actually be considered excluded from even being able to access this treatment or for clinicians to feel that this treatment would be effective for them. That has been a huge reduction in opportunity where 30% of the patients that actually went in for PE treatment had these particular behaviors and needed this treatment because of their PTSD. And some of these behaviors they were struggling with because of the PTSD. However, we're not able to access that care. So the thing that we want to consider is when Melanie Harned was looking deeper into borderline personality disorder, which DBT is known for treating historically, they started to realize that if we are going to include PE in this DBT PE protocol as the chosen trauma treatment, we really need to figure out how can we start to build more evidence that you can treat borderline personality disorder symptoms with prolonged exposure therapy and PTSD, and that it's effective. So if you're not familiar with the borderline personality disorder diagnostic criteria, this is just a quick overview of that. A lot of the exclusionary criteria that we just went over is a part of this. And along with the treatment, so along with PTSD and using DBT, some of these behaviors will come up and you'll want to target them. You'll want to assess them and really work on them within the treatment of PTSD because they will also be an interference of the success of really reducing that PTSD. So when we kind of look back, there were myths. There were myths that we as clinicians, even the greatest of clinicians when it came to trauma, believed that if we were to actually start to work on the trauma and these behaviors were present, psychosis, suicidality, self-harm, substance abuse, borderline personality disorder, these complex comorbidities along with the PTSD, that it would exacerbate the symptoms of the PTSD or exacerbate the symptoms of these comorbidities and cause the patient to be in even more danger. So even as clinicians, we had a fear structure around the treatment of trauma. We felt that if we continued or tried to treat the trauma at this particular intersection of these behaviors and these comorbidities, something bad would happen. And so what we ended up creating for ourselves, which is completely understandable, were our own avoidant behaviors and our own interfering behaviors in the therapy as well. And so DBT PE created a protocol for the therapists as well to really help them build this consultation and this ability to begin to work on it. Jenni, did you want to share a little
time in here? Yeah, and I wanted to let you guys know, if you weren't on our last webinar, whenever you see that little bamboo symbol on the slide, that means I'm going to say something. So here I am again. And I put that book actually on this slide, Treatments That Work. It's a series of books related to treatment manuals, and this is actually the patient workbook that goes along with the prolonged exposure therapy manual, something that you guys might buy. I bought this book because even though, like I said, I'm not a clinician, as an author in the field, I have so many clinician friends, and I am so grateful for that. So once I finally realized that I had PTSD, I called one of my friends who is an expert and said, what kind of treatment should I do? And she immediately recommended this book. So I bought this book, and I'll tell you what I thought, well, this will be easy. I'll go online in Austin where I live, and I'll find someone who can do prolonged exposure therapy. And I was shocked to find out that in my city of Austin and surrounding areas, which is rather large, there was about 1 or 2 people that actually had been trained that I could find with prolonged exposure therapy. And luckily, I was able to get into one of these gentlemen, this one doctor. What's interesting to note is that a study just done in 2016 by Dr. Trottier is that 18% of clinicians who treat eating disorders report using evidence-based PTSD therapy. So 18% of people who treat eating disorders report being trained in a protocol like PE or some kind of evidence-based therapy. So part of our mission really is to hopefully get lots of people interested in the DBT PE protocol so that when patients buy this workbook and they look for people to help them, that they can really find help. And gratefully, I did find a clinician who was trained in PE, and this was an expert clinician. I did PE for a long time on an outpatient basis, and I say a long time because I actually saw him for a couple years. And if you're any bit familiar with the protocol, which Lara will get into a little bit longer today, you'll know that the typical protocol for PE is not anywhere near 2 years. What's important to note about this treatment I was doing was that I was experiencing relief. I was not getting fully healed from PTSD, and I do believe that's possible. Trauma doesn't go away, but PTSD can. But I was not learning DBT skills. So that's really the point I want to make here is we were strictly doing the PE protocol, which truly works wonders, and for many people, that's exactly what they need. For me, again, kind of more of a complex case, I learned that I needed something more. Now, at this time, the DBT PE protocol was not out. It hadn't been distributed. So we really did the best we could at the time, and that was PE on an outpatient basis. And even though it didn't fully help me, I did get a lot of relief. In fact, I actually would bring this book to therapy and beg my clinician, can we please do the PE therapy? Because sometimes if you treat trauma, you know that you can get distracted by talking about other things in life. I call that chit-chat about all the problems that PTSD can cause. So one of my main points of this slide is just that even though I was scared of the treatment in many ways, what I know is that treatment is scary. Many treatments are scary. But what's worse is staying the same. PTSD is way worse than any treatment for PTSD could ever be. And the great news is that I did not, again, to emphasize, I did not relapse into my eating disorder, even though I found this treatment very difficult, especially at first. And stay tuned because we'll get into more of my therapy where eventually things started clicking. This all has, I'm going to kind of do a spoiler alert. We do have a happy ending here, so hang tight with us. And I will pass it back to you, Lara.
Thanks, Jenni. So, one thing that we want to just talk about, especially when you work with complex patients who have the high-risk comorbidities, is that we all kind of sit with the patient and we wonder, where do I begin? What is the highest priority target here? And so that's where the DBT, the basics of the DBT protocol are so useful for us. And one thing that Melanie Harned had given us, the approval to do this presentation, and we've been doing this presentation at multiple conferences all around the nation this year, and it's been, a wonderful opportunity for us to really share this amazing work. And one of the things that Dr. Harned continues to say over and over again in her trainings is that this initial idea that Dr. Linehan had when she first wrote her cognitive behavioral book for borderline personality disorder, and what it was that even Dr. Linehan had the thought that, yes, we do need to help these patients with their post-traumatic stress disorder, that their post-traumatic stress disorder, if they have that, is actually causing them more suffering with borderline personality disorder than without PTSD, those patients without PTSD. And so we must get to that point where we can treat it. However, the timing is needing to be very mindful, very thoughtful as to when do we approach that. And so Dr. Harned kept that in mind throughout her time of developing this protocol to ensure that we really were able to treat all levels of risk. So like I was saying before, we continue, Dr. Harned chose prolonged exposure therapy over other treatments, she does state that other evidence-based treatments can be used. Cognitive, processing therapy, EMDR is also useful. Anything that has an evidence base that goes along with the same philosophy of the protocols of DBT will go hand in hand, will work with this because the language is similar. So it's not as though one versus the other is important, but prolonged exposure therapy became for her because of the evidence behind the treatment. She felt that it was the most in line with the DBT, with DBT evidence as well. So for those who are not familiar with prolonged exposure therapy, it is a protocol-driven treatment in which you are given steps as to what you follow, and I will go over those. For when you first meet with the patient, you are going to follow the steps of the protocol, and then when you go into the treatment, there's protocol to that as well. But one of the things that's very important about these particular steps is that trauma treatment is also an art. And so we want to have the science, we want to have the steps to help us have a map as to where to go and where to follow, which really does help as a clinician to build that confidence, to build that understanding of why this treatment is going to be useful. Because a lot of our work is actually trying to support the patient and trying to help the patient build understanding and trust in the treatment and then themselves, right? Because trust is so precarious when we're working with trauma because it's been broken so many times. So how do we start to help them find that trust in the treatment? And protocol is really useful. And the reason is because it's all about orientation, constantly communicating with the patient what's ahead, what we're going to do, why we're doing it. And there's knowledge and fact around that. And then there's also the collaboration, asking the patient to include their thoughts when their readiness, what they would like to do with that particular next step. So what we really start to work on for our patients, and with this protocol, like I was saying before, they are facing their fears. They are doing opposite of what their brain wants to do, which is this emotional processing theory of PTSD, which is starting to face those thoughts, starting to face those emotions, memories, cognitions, and the ways the core beliefs, the erroneous core beliefs that they developed because of trauma, like Jenni was mentioning, putting on those glasses and seeing the world in a particular way, we're asking them to start to maybe think that those glasses were there for a reason, to protect themselves from being harmed again. However, what if there's a way to tolerate life and all of its uncertainty without believing that there's always danger ahead? So like I was saying before, when we first started to introduce, we are going to start to work on this exclusionary criteria. We are going to help the patient begin to work on these interfering behaviors that are causing the difficulty of reducing that PTSD, and how to start to target those as well while you're working on the PTSD treatment. And that's where the most important, theory of this came, which is we need an integrated treatment. We need to combine protocols, the DBT and the prolonged exposure therapy. So for DBT protocol, what it is 3 stages. The first one is going to be the DBT skills training. So think about building a house. This is where we are building that cement base. We are building the foundation in which we're going to build increase in intensity, we're going to increase in challenge of that patient, and they will have that foundation to support themselves and to manage that intensity along the way. And so we'll do that through assessment, orientation to the phases, orientation to the treatment, psychoeducation around what is prolonged exposure therapy, why is it used for PTSD, what is PTSD, so all the hypervigilance. So when I start to educate my patients around PTSD and what they're experiencing, some of them are just so relieved to know that this actually exists for someone else, that this is diagnosable, and that is the reason why they've been struggling day in and day out with their lives. And then we're going to move to the stage 2, which is the DBT PE protocol. And that's where we're going to start to ask them for more of that history. What actually happened? where are we going to go in this work together? What memories are haunting you, essentially? Now, through this process, I want to be open with them about the fact that they are leading me through this, that we are going together, but at first, I don't know what has happened to them. They are the keepers of this information. And if they withhold particular past events that really had a huge impact on them, then this is going to be, and then they don't tell me, I can understand them not being ready. However, if I don't know about it, it's going to come up for them. It's going to actually maybe be a hindrance to them to feeling like this treatment is a benefit. So really kind of, and I'll talk more about that, is that we're going to really try to work with them about being as upfront as they can and as willing as they are to try. Then the stage, and then also in stage 2, we're going to be doing in vivo and imaginal exposures, which I'll go more in depth around. And then stage 3 is building a life worth living. So building that values, building the long-term projection of their lives, and taking the moment of recognizing I can't control the things that have happened to me, but I can move forward. I can build a life that I want from starting tomorrow. So overall, Marsha Linehan and Melanie Harned started to go deeper into, well, why is this going to be useful? Why isn't DBT able to treat PTSD on its own? And so what is it about DBT PE? First, they needed to control for that. Is it the DBT that's treating the PTSD, or is it really the DBT PE protocol? And over time, they started to realize that no, it is the DBT PE, that DBT PE doubles the remission rate for those who have PTSD and are among treatment completers. Also 2.4 times less likely to attempt suicide and 1.5 times less likely to self-injure, and those just in DBT alone. Also, among treatment completers, they favored the DBT PE protocol due to its reduction in dissociation, trauma-related guilt cognition, shame, anxiety, depression, and overall increasing this higher global functioning. And we started to see that you can use this for a variety of, genders and ages. Women had a really great positive, effective response to this. That 74.1% of them were actually completing the treatment. And they had strong improvements in suicidal ideation, dissociation, all the things that I just shared prior. And then they also looked at in VA, so working with males, 51% of the patients were male, and the 67% completed, 0 dropped out during the PE protocol, and they had significant pre-post reductions in PTSD, borderline personality disorder, suicidal ideation, anxiety, and depression. And then they also started to look at, we're starting to see for even adolescent girls working on PTSD, and 75% of the clients in the DBT PE protocol versus the 25% of the clients in DBT achieved significant diagnostic remission from PTSD. Those are amazing results. These mirror the results that prolonged exposure therapy showed with the exclusionary criteria if used. So this is those that have those high-risk behaviors, those high complex comorbidities, and they are seeing with the DBT PE combination that they're having the same effective outcomes. So the thing that we've come to understand as conclusion that DBT PE is effective. It is going to support the patient to not drop out, to continue with the treatment, to not exacerbate the symptoms in which we as treatment providers are afraid that will be exacerbated. And it actually shows promise to be supported in a community setting, to allow a patient to do this in outpatient therapy, to do it in many different types of levels of care. We do it in residential and partial hospitalization and in IOP, and we can follow the patient throughout those steps because it's about making sure that the patient is ready, that they're able to move into that stage 2. So overall, it's effective for not only the patient but the therapist. It's safe to administer. And just speaking, from my own experience of really, doing prolonged exposure therapy without the DBT PE protocol and then after the DBT PE protocol, it actually was really well received, not only for, my patients, but also for the clinicians that I was working with and, trying to collaborate with, where they were worried about the exacerbation of symptoms. They were worried about the patient. And so we had using the protocol, being able to explain it to those that do not do PE treatment, they started to understand the protocol more. They actually saw where we were going and felt that it was in line and effective for the patient. So I feel that the DBT PE is not only beneficial for the patient, for the therapist and the client, but it's also beneficial as a tool to help with collaborating with other providers as well. So I'm going to go deeper into the stages and talk a little bit more about that now that we know why this has become effective. The outcomes have shown that it's effective. So in the stage 1, we are going to work on the DBT treatment. This is where we're getting back to the basics. We need to know the foundation. Now in stage 1, a patient can be here for 9 months and not moving into the actual retelling of their memories. And the reason behind that is because everyone is different, as we all know. It's a thumbprint for the patients that walk in the door that say that they are, have a history of trauma and that they want to work on this, or that we have recognized that they have PTSD, but there's all these other comorbidities or high-risk behaviors going along with it. So we want to be targeting those behaviors. We want to see that the patient can move towards a higher intensity and be able to tolerate that while effectively using their skills, managing it in therapy, being open about it. If you do phone coaching, that they're reaching out to you, using that phone coaching effectively, and not finding that they're using behaviors and then reaching out for help, or having high suicidal ideation or high levels of dissociation and not managing or tolerating those intensities. So those are indicators that we're still in stage 1. We're still needing to work on the DBT basics. We're still wanting to build that foundation, because I kind of talk about trauma treatment like we're sitting by a fire. And as we, myself as the provider and my patient, we're getting closer and closer, we're sitting closer and closer to this fire. And so we need to be ready for that. We have to slowly acclimate to the intensity of this trauma work. And if we're not tolerating it where we're sitting, let's sit here and work with it a little bit more. Let's really build that tolerance so then when we get closer to those higher intense emotions, you're not going to go back to those maladaptive coping behaviors. So we want to stabilize high priority targets, reduce life-threatening behaviors, reduce therapy interfering behaviors, and really be able to target some quality of life interfering behaviors. And recognize that substance abuse and eating disorders and other comorbidities can be present while working on the trauma. You don't necessarily have to see them completely go away before you move on to stage 2. However, they are managed, they're monitored, and the patient is willing to work with them. Substance abuse, the patient is not coming to sessions under the influence. They're not using substances after the sessions to manage those emotions that have been elicited during the treatment. And instead, they're willing to work on it. We are, DBT is a harm reduction model. We are willing to work on the reduction of use, and then the use is not engaged based off of intensity or need to numb out or as a maladaptive coping skill. So this is becoming the contingency. We cannot move forward. It almost becomes the carrot on the stick for some of the patients. I can't move forward with PTSD treatment until I see some improvement in these behaviors. No self-injury, no suicidal attempts of significance over the past 2 months before starting the PTSD treatment, or 1 month and if they've been in higher levels of care, such as residential. That they're willing to work on goals and that they can link those goals. So what are their values? What are the greater things that they are wanting to work towards in their life? And do they have some internal drive towards those values? And that's going to be used to our benefit over time, because going towards something intense like their trauma memory is going to be challenging. And so how to coach the patients through that, and that they have an overarching value that they are striving for. And I always say to my patients, What is the purpose of facing this suffering? Because you want to be closer to your family, because you want to keep your children, because you want to remain in school, you want to have a good job, you want to have a relationship. These are greater things in your life, and they need to be able to identify those. So this is the standard timeline, and then we orient our patients to this. Again, we start with the stage 1 and the skills training, and we're going to stay in there until we've assessed and we've really gotten to a place where we can move forward. Then we'll be in the stage 2 in the DBT PE. If you have done prolonged exposure therapy in the past, you're familiar with the traditional 90-minute session. Those are excellent. We don't necessarily want to say that they're not effective, especially for the patients who are just starting with this treatment. It tends to help lend that opportunity for more of that the stabilization when they're feeling destabilized after even just talking about their history of trauma. And so we'll do grounding and we'll do deep breathing and so forth and helping them stabilize to move on. However, DBT PE research is starting to show that 90 minutes is not only the effective magic number to making sure that PE is effective. You can do it in 60-minute sessions. You can do 2 60-minute sessions, 1 PE session, 1 DBT session, or you can do a 1 60-minute session where you're doing the PE in the session together, and then they're attending a DBT program group where they're going over the skills, they're practicing the skills, and they're using them effectively. And so what we're going to be tracking throughout the PE as we're doing it together is we want to know right off the bat, and that's going to be a part of the trauma assessment, is what are you avoiding? What are the cognitions, the cognitive avoidance? What is the behavioral avoidance? People, places, things, also the thoughts in which you have. What do you do to reduce your emotions or the fear? And also the problematic beliefs that are associated with your life. So for instance, no matter what I do, I'm never good enough. I'm bad because this happened to me. It's my fault. No matter what anyone says, I'm the reason why this did happen. So, or the beliefs about the danger, no matter what you say, no matter how many exposures I do, I will never be safe. Those types of cognitions are problematic in the reduction of PTSD. And so those will be the avoidance behaviors and the problematic behaviors. Those are the 2 core arching parts of PTSD that exacerbate them. And we want to be targeting them, and we want to be working on them. And the thing that we want to be supporting our patients with this PTSD education is recognizing that they understand the diagnostic criteria, that we've gone over that with them, and then that there are common reactions to trauma. This is essential in the stage 1. We want them to know what has caused the PTSD, why they've been diagnosed with PTSD, and how trauma memories slowly are retraining the brain to fear everything. So let me kind of tell you a quick story about how this happened. So if we were all sitting on a park bench in a forest enjoying our lunch, and then all of a sudden this bear comes out of the woods and charging at us, I can tell you the first thing that we do is jump up and run for safety, which is the van in which we came in, and we safely get into the van and we drive away. Nothing happened to us. However, the event of the bear charging us and the flash before our eyes of the loss of our life was traumatic enough for some of us. So later on down the road, what we're going to do is our brain is going to want to find potential dangers that this could happen to us again. So you might be driving by a park bench, flash, all of a sudden a bear charging at you. You see this forest, this beautiful day, the situation in which we were in, flash, you see a bear charging at you. Or just even waking up in the morning and not really knowing, if I go for a hike in this trail, there could be a bear. And the reason for this is because the brain is built to help us survive, not to be happy. So if there's a danger, a potential danger around us, our brain is going to hold this information for us, and it's going to cause us to remember it in many different ways. Now, imagine, so as you know, some of our patients have been through significant chronic trauma. It's repeated trauma over time, and which causes complex trauma. Now, the brain starts to hold these memories and these flashes of the danger, and it becomes almost like a Swiss cheese experience where there are holes to this memory, and everything that has happened to them starts to get really disorganized and disheveled, and they don't really know what is what. However, these symptoms or these situations or these senses, they cause and elicit the whole body to respond that there's danger around them, and it happens more and more again. So that's what we want to explain to them. The reason why this happens to you, and it's such an acute level, is because your brain doesn't even know what's dangerous anymore. It has no recognition. It wasn't just one event. It wasn't just one situation or person, place, or thing, or one sensory experience. It starts to just take this filing cabinet that it has, and it's completely in disarray. And what trauma treatment is all about is about helping you try to find organization to these files, to try to help through one exposure at a time the brain to start to see that not everything is a danger anymore, and that you can refile and recategorize danger again. And you can start to see that not everything is going to cause that. Not every picnic table is going to be a danger. Not every forest is going to possibly be danger. It may elicit that fear, however, your brain is going to override that, and you're going to have a sense of, oh, actually I can be safe in the situation. And the other thing that we want to, kind of map out for them is recognizing that there are common reactions to trauma throughout this, in which we have the behavioral regulation, so you have the under-controlled and the over-controlled. So the patients respond differently to trauma. They have under-controlled behaviors where they are impulsive, emotionally reactive, and have excessive intimacy. They are externally responding to their trauma responses. And then they also have the over-controlled, which is an internalization of this trauma experience, where they have excessive independence, emotional avoidance, and compulsive behaviors, and high rigid beliefs or rule-bound behavior. And this is causing them to get caught in either trying to, find relief through that under-controlled behavior, or find security and safety in the over-controlled behavior. And we talk about that, and I definitely map out for my patients where their behavior tends to lie and how we're going to work on that. So moving on to stage 2, and this is where we are going to help the patient work on a trauma interview, identify the traumas. So we're going to target up to 3 traumas. They tell me the whole trauma just like how Jenni went through her whole cycle. It's very similar. I want a timeline. I want to know what happened and each event that could happen and variety of intensities for you. And then I'm going to start to categorize those traumas and rank the distress. So just like I would build a hierarchy for exposure work, it's very similar to this for the trauma assessment. And PE starts with the most distressing memory. Now, one thing that I do share with my patients is let's start with the most distressing memory that you're willing to tolerate. And this is where I ensure that even though you're not ready because you don't feel like you can tolerate this memory, I need to know. Because if we move forward and we are doing the second most intense memory, that first most intense memory, even though you're not telling me, is going to creep up, and it's actually going to cause more havoc on you than if I did know and I know why. So I can be that navigator. I can support you through that. Then we're going to talk about traumatic invalidation. A lot of patients do not believe that invalidation is traumatic enough, because a lot of people are comparing their traumas already and feeling that their trauma is not bad enough, where other people have had it worse. Traumatic invalidation is essentially where they may have told someone that the trauma occurred to them, and the person's first response is, don't tell anyone, that didn't happen to you, I know that person, they would never do that, you must have been mistaken. Or even, thinking about people who don't necessarily intend to come across that way but do, based off of system issues. So even going into a court, I've heard stories about going on trial, really feeling like you're hoping to get your perpetrator, and the judge asks you, what did you wear? That in itself can be invalidating and cause traumatic invalidation. So what happens with traumatic invalidation, and a lot of times research is showing that the traumatic invalidation can actually have more impact on the individual than the trauma event itself. That someone could have invalidated that experience to them, increased that shame, increased that inability to accept the trauma so much, and the anger and the loss and the sadness. So throughout the trauma, when we're working on in the exposures, we're going to be tracking the emotions, looking at the shame, looking at the fear, the self-directed disgust, the self-blame. How much do they radically accept their trauma? And also hotspots. So as you're starting to work on the trauma, you're wanting to see when is their distress the highest as they're retelling. So in prolonged exposure therapy, what you're doing is you're sitting there, as you've identified what trauma you're going to do, you're going to have the patient sit and they're going to verbally describe, go over what that memory was. And so this is called in vivo exposures. Imaginal exposures. And in the imaginal exposure, what we're going to have them do, prolonged exposure therapy protocol, is to sit with your eyes closed and to begin to share the memory and retell it aloud. And the therapist, myself, will be sitting there and listening and taking notes. And I want to be writing down everything that the patient is saying, word by word, and also any sort of cognitions, those erroneous cognitions that are coming up, the way in which they're managing it. And then I will be asking them their levels of distress from 1 to 10 throughout. And what I'm asking them to, the purpose around this is that they have their eyes closed, they're doing it in first person, that we're recording them retelling, and the whole purpose around that is because we're trying to have, like I was saying, we are reorganizing this memory. We are trying to build it so that it starts to face the reality of the memory rather than the way that the memory was stored. And this is where we're talking about inhibitory learning, because the new learning, the starting to experience this memory in a new way happens based off of the retelling with the therapist in the room, but then the second part, which is then listening to the recording of you telling the story. And then the person is listening to themselves as an observer and hearing how are they internalizing this story, what are they feeling, what's coming up for them, are they numb, what is that reaction about? And then along with that, we're doing in vivo exposures. And this is where we're taking events or situations in their lives in which they're avoiding or that have affected them to the point that it's impaired them. And we're starting to work towards that. So for instance, I had a patient who really struggled with just being out in the community or out walking around without all of her safety, like her self-defense toys. So there are these hard plastic defense toys that have spiky edges. You might have seen them. Maybe some of your patients have them. She had a huge collection of them, and she kept them in her backpack, and they weighed about 3 pounds total. She would carry them wherever she went. And the reason why we started to target this is because it was a signal to her brain that no matter what, she was always going to be in danger, and this was going to prevent her from, being attacked or being in harm's way. And so we started to do exposures around her walking down a busy street during the day without them, and I would hold on to them. And she would do this for 5-10 minutes and increase the intensity of the time, the length of time, which would increase the intensity. And so those types of things we would be working on, we'd be making a list of them. And again, we would be tracking how are they managing, how are they working on these exposures, because we want to be kind of tackling these fear structures from both sides. We want to be tackling it from the PTSD, but then we also want to be tackling it from the avoidance perspective, so the problematic beliefs and the avoidance behaviors. So we'll be tracking.
Laura.
Yeah.
Laura,
I'm sorry,
this
Jenni.
There's that bamboo. to bamboo. I was actually so excited hearing you. I almost forgot to talk myself, but I just wanted to reiterate some of what you were saying there. And for some people, and I know we discussed this when we spoke at a conference this weekend, many people can actually think, well, this treatment sounds kind of barbaric. You're making someone face their fears over and over again. And I actually want to read a little bit from a journal entry I wrote after I had done prolonged exposure effectively, and after I had listened to my trauma script over and over again on my iPhone, which was part of the imaginal exposure. My journal says, now listening to my trauma script feels very helpful. It's like my brain is rewiring. It's like my brain is finally learning this is in the past, and that's underlined. This is in the past. It's hard to explain, but it's a subtlety where I feel like memories are actually being filed in the right place. Keeping my trauma script and listening to it over and over again keeps my brain online. So that, to me, just shows the freedom that I experienced in this. It was difficult, as I said. In fact, the first time I ever tried imaginal exposure with the outpatient therapist I spoke about in Austin, I actually had a panic attack, and I hyperventilated. I couldn't breathe and ended up breathing in a paper bag. Now, if you remember my timeline in the beginning, panic disorder is not listed on there. I never in my life had ever had a panic attack except one other time, and that was jumping out of an airplane. So you might think, well, that's adaptive. Jumping out of an airplane, that's actually life-threatening. But so why was my body reacting to a memory of something that happened 12 years ago in the same way that it reacted to plunging out of an airplane going 100 miles per hour at 15,000 feet? Why is that? And why did I stay with the treatment? Well, because I was actually experiencing great relief, and the panic attacks, they started dissipating. As I mentioned before, I was not able to recover in a purely outpatient setting, seeing a therapist twice a week. What I actually needed to do was go to a higher level of care. I went to a higher level of care, a program that specifically treated PTSD. It was not an eating disorder program. It was a PTSD program with a focus on prolonged exposure. The great point here was that I was finally starting to learn DBT. Now, this was not the DBT protocol because, again, when I was in treatment, this did not exist. It wasn't really anywhere. However, the program I went to had DBT groups. I was starting to learn some skills. And if you remember Dr. Stone's talk last time, she talked about the 4 modules of DBT. I learned 3 of those. I did not learn distress tolerance. My treatment team was afraid to teach us distress tolerance skills because, as many of you know, if you're trained in PE, patients are not supposed to use distress tolerance skills while you're in an exposure. However, I actually needed to use those skills while I was not in exposure. So while I was alone at night or while I was not in the group, I didn't have those skills because the treatment program was afraid to teach us those because, again, they didn't want us to use those in exposures. So I actually was still struggling with PE. Many of you are probably wondering, why did I stay? Well, because, again, I was getting some relief. I actually was told by the program that I might not be able to handle the program. I was really having a lot of PTSD symptoms really outside my window of tolerance. I almost had to leave the program, in fact. But before I had to drop out, the program actually gave me a chance to go to the psych hospital, and there I was able to essentially reset. It was like rebooting your computer, you might think of. And actually there I learned more skills, and I did learn some distress tolerance skills, and I was there long enough to really get that safety and stabilization that I never had gotten enough of before. And if you think back to my timeline, being highly sensitive, having that fear circuitry turned up, I was a patient who I now know, we all now know, that I needed a lot of safety and stabilization, maybe more than most people. And the good news is, after the stay in the psych hospital, I went back to the program and I was actually able to complete the program. And that truly set me free. And I'm so grateful for again, all of you guys who do this kind of work with trauma. And as a brief example of an exposure, because they can be so many things of in vivo, which means real life. One interesting exposure I actually did was involved Cosmopolitan magazine. Now, I don't generally read this magazine, but I'll tell you what, when I was in treatment, I had to read it a lot for hours a day because my brain was afraid of any woman's magazine, because if you think of words on women's magazine covers, it's often about intimacy, relationships, and of course that reminded me of the trauma. Just like Lara talked about, if you had a bear chasing you, being in a van might remind you of the bear charging at you. Cosmopolitan magazine reminded me of the bear charging after me. So part of my treatment was literally sitting in a room, going through a magazine, and being able to look through each page without having a startle response eventually. And the startle response did go away, and it's actually quite freedom to be able to walk through a grocery store, to be able to glance at the magazines that we can't help but see because they're everywhere, and not startle and not be afraid. I used to be afraid in the grocery store checkout line. So again, that's just some personal examples of how this worked for me and how I shifted from being in total panic to actually being free to where I can actually talk about it now with you guys, and I don't have anxiety around it. So anyway, but now I will pass it back to you, Lara.
Thank you. So one other thing, and Jenni, and thank you so much for kind of talking about all of that, and that journal entry was incredible, because that's exactly, a lot of the patients that I've worked with that really, felt captured and, a prisoner of their, not only of the, what had happened to them and the loss of control and everything that was taken from them, but also what they really felt like was they had no way of having that positive experience in their lives. They felt like that was robbed from them. And after they started to do the PE process, they really, and it was effective for them, and they were able to complete it. They had the same experience as you did, Jenni, and they really were able to kind of talk about, wow, I actually have other emotions than just fear. I experience love. I experience happiness. And a lot of that is because of that rewiring, that ability to reorganize their memories, because like I had said, not everything now is dangerous. It's categorized appropriately. And they know how to.
Yeah, and it was like the glasses came off, those PTSD glasses. They came off, and I can see clearly now. I think that's a song. Maybe
Good
next
song.
time we'll sing for you guys.
It is a song.
Stay tuned for part 3.
So emotion tracking, what we're trying to work here is, not just the things that I have written here, but we're really trying to target for us as information as the therapist is what are the interferences to the reduction of PTSD. As we're starting to work on this treatment, what is becoming a barrier to them actually gaining more relief the more that they're doing the retelling? Because like Jenni had said, just going over this is difficult. However, we're trying to see there to be some movement of relaxation, of movement of kind of finding distance from what was once. It felt like every single time I'm going to talk about my trauma, it's as though the trauma is happening to me again. And instead starting to see, no, this did happen. I was 15 when this happened, and I'm 32 now. I am 32, I'm not 15. Every single time I start to face these things, I can recognize I am 32. And all of these indicators, these tracking, these numbers are going to be our guide. They are going to be the raw evidence that something is moving, that something is changing, along with assessment tools. We want to be using tools and looking at whether or not the PTSD is going down, whether their self-reports are changing, and so forth. So we want to look at the preconceptions. Is it a high probability? Are there high cost estimates? So what is the worst that could happen in this situation? And having them tell that to you, those erroneous cognitions. What is the worst that could happen to me if I do this retelling right now? What is the likelihood that this could happen to me? And how bad would it be if this happened? And then after doing the retelling, I go back and I said, okay, so the worst thing that could have happened, did it happen? Yes or no? And then if it's yes, if it did happen, how bad was it that it happened? And then we kind of talk about that. And always, their erroneous cognitions do not have as high of a probability or have as high of a cost estimate as they do in reality. And that is the relearning. That is the learning safety, the safety learning that we want them to be acquiring over time, is recognizing that just because their emotions or their thoughts happen does not mean that they're true. So the signs that DBT is working. Their problematic beliefs are changing, their unjustified emotions are decreasing, and PTSD is improving. So moving on to stage 3 is building a life worth living. So starting to end those unhealthy relationships, building relationships that are more in line with your values, going back to work, going back to school, continuing the treatment aftercare program. So seeing, really working on that inhibited grieving and recognizing the residual sadness and starting to work through that, and increasing self-validation and compassion, increasing meaning and purpose, no longer believing those erroneous cognitions, and starting to build a life based off of this new vantage point. We also want them to become their own exposure therapist, and the acronym is FREE. Now, if you know DBT, they love acronyms, so we are not saved here. We have another acronym, which is fight fear, do random acts of exposures, enter difficult situations, and embrace emotions. Keep going towards the things that challenge you. Keep building, because life is going to continue to happen. Stressors are going to continue to happen. How can you continue to reduce the hyperarousal, the overwhelm, or the under-controlled behaviors, or the over-controlled behaviors? Because that is still going to be a mechanism in which your brain or your body are going to want to find relief or try to find safety again. And so how to work with that and how to continue to build those exposures, and that will help reduce the ineffective behaviors that they work so hard to reduce over time.
Yes, and this is the big bamboo, which we're going to tell you why we chose bamboo to represent me. And I want to also reiterate what Lara said on the last slides. Treatment really is about finding a life worth living, and I can say that once again, I found a life worth living. I recovered from PTSD and truly found myself, and it's about what Lara said. It's values, it's meaning, it's trust, it's shifting in those negative beliefs. And I really love what Lara said about you can't change the bad things that happen to you, but you can move forward. And the reason we chose bamboo is because it's a metaphor that our patients actually love. If you know anything about Chinese bamboo, I'll tell you the story real quick. Basically, you plant the seeds. In the first year, you might water and fertilize, and nothing happens. There's no growth. And second year, you water and fertilize again. You go out, you look at your bamboo plants, and there's nothing there. It's just dirt. So you're probably getting a little frustrated, just like I was getting frustrated in my treatment when I didn't think I was getting better. And then third year, nothing happens again with the bamboo. So it goes on until the 5th year, you still water and fertilize, and at this point, getting pretty frustrated that you don't see any growth above the ground. But all of a sudden, sometime in the 5th year, the bamboo will actually shoot up about 80 feet in 5 weeks. And our patients love that metaphor. I love that metaphor, because how many times do your patients tell you, I'm not getting better, I've been working hard, I've been at this for years, nothing is changing? And the truth is, like the bamboo, things are changing. In fact, all that treatment I went through, it was all putting the puzzle pieces together for me to heal. I needed every bit of it, starting with the EMDR that I had about a couple years after the trauma happened. And so what was really happening was I was building a foundation underground so that when my bamboo shot up, it could hold a bamboo piece that was, 80 feet. So I hope that makes sense to you guys, and I hope that's helpful to your patients. We're actually going to send you an article that you can share with them. And it's really just to give hope that sometimes this is a process, but a lot of times when you don't know it, you're building this huge growth, this root system under the ground, so that one day you can shoot up and you'll be strong enough to support that growth. So we want to thank everybody for joining, and I want to thank Lara and Dr. Stone for letting me tag along on this one with you. And we want to take some time. We have a little bit of time for questions. So we're going to move along because they're actually typed up for us already. Oh, here is this study. I think I caught, so someone's asking what study was I talking about. I think this was the one that I mentioned about the 13.6 years. Is that accurate? The one about patients would be willing to give up 13.6 years of their life. Is that the study? If that is the study, it's actually a 2011 study that was done. We'll send you the citation on that, but I actually have the study here though. It was done in psychiatric services in 2011. It was called The Predictors of Health-Related Quality of Life Among People with PTSD. So that's the study about the 13.6 years when people said they'd be willing to give up that much of their life. If that's the study, I think that's the one because I was kind of following when the questions came in. If it's not, send us an email and I will give you any other studies that you have. And then I think the other questions, are there any clients you would not use this on? I mean, Lara and Dr. Stone, do you guys want to tackle that?
Sure. So this is Lara, and in regards to are there any clients you wouldn't use this on, studies are showing, and there have been many different trials and many different study comparisons done that look at the exacerbations of symptoms, and they really haven't found anyone that wouldn't be able to do this treatment. Just some of the things that some not necessarily exclusionary criteria, but things to be mindful of is that it is really hard to do retellings on memories that are have a lot of missing details, and so they do not have a full memory or a full kind of picture of what did occur. However, there's a lot of stressors, or there's things that they do remember, or they don't know whether it did happen to them. Sometimes it can be hard to do retellings around that, and that can sometimes be frustrating for the patient, and so that might be an interference to the effectiveness of the treatment. Also, it's not as though that you wouldn't want to do the treatment. You would just with like severe dissociation, or when I was talking about suicide attempts or self-injury, that instead you would want to stay in DBT stage 1 for longer periods of time. You would want to help them manage that, and then you can do stage 2 when you see that they're able to tolerate higher levels of intensity. Also, the other thing that they're starting to look at is schizophrenia. Now, for those with active psychosis, it's not as though that you can't do this form of treatment. It's just that at a certain point, it may be difficult for the patient to know whether or not this is the psychosis or whether or not this is the trauma. And so that one you would want to continue to just assess and gain consultation around as to whether or not the patient is ready or is able to tolerate the trauma treatment. Anything you would want to add, Andy?
No, I was going to add the psychosis piece. So there's nothing else I would add to that.
Okay.
We have another question, you guys. Can you see it on the screen there? Can you do a PE when a client continues to be exposed to a person greatly influence the negative beliefs? A client with anorexia who is extremely hard on herself, as was mentioned in the presentation, she doesn't have any real trauma, in quotes, so gets frustrated. However, as the therapist is getting to know her, I'm learning that both now and growing up, the mother blamed her for anything that happened. If she got a cold, then she'd ask why she got the cold, and it says that the client just got out of the hospital and her mother is telling her that her eating disorder is all her fault. So do you guys have suggestions on that?
I do. I don't know. So this actually came up in the advanced training for DBT PE, and one of the things that is really useful with this is when the patient is struggling with an active person who's extremely invalidating for them, and it just kind of continues to cause more of that traumatic invalidation, that you actually start to target that. And so, for instance, this particular patient that this was happening to, they were living at home with their parents, and the parents were doing very similar things. And so they started to have kind of secretive internal dialogue about their parents. So they would almost be reducing the power of their parents' responses or comments by having, more of their own internal response that they wouldn't share with their parents. And so it took back the power for them. So there's ways to help them work with how their parents, the shame or the anger or whatever the emotions are coming up for them, having them do those in vivo exposures where they're starting to actually negate the power that the parents are trying to take away from them. So we want to empower the patient. We want to build self-validation. We want to build self-esteem. And so there's ways that you can do that with the in vivo exposures, and they have found that that was effective. Now, this is a particular example because you went into more detail where the mom is more of, verbally abusive. I would say that it's very challenging to do this with, physical or sexual abuse. And so a lot of times we would still want to help the patient reduce their PTSD. We would, again, this DBT is a harm reduction model, so this is the art. These are the principles of DBT, is that we want to help them get to a place where they can get themselves out of this environment that causes them to continue, it's that cycle. So we're trying to break the cycle. I hope that answered your question. I don't know, Andy, if you would add anything.
The only thing I would add is just thinking of if you're practicing and using DBT skills, the interpersonal effectiveness module might be a place where we stay in stage 1 DBT so that she could really learn those skills and practice those skills and try to gain some mastery in communicating with her mom, even if her mom doesn't change. Similar to what Lara is saying, it's like changing the way she relates to her mom's comments. And DBT can be offers a lot of skills in that area.
So the next question, any recommendations to helping establishing trust and safety? And I personally love this question, and one of my supervisors for prolonged exposure therapy, I felt like put it in a really wonderful way, which is he was saying, I don't ever expect trust in my relationship or in my therapeutic relationship when I'm doing PE, because trust is so precarious. If I try to focus on gaining trust and gaining my patient's trust, I could be waiting for a very long time because, like I was saying, the reason why they have PTSD is because of the things that have happened to them, and those erroneous cognitions, those ways, the thoughts, the emotions, the ways in which they feel is not because of me. It's because of their PTSD. And so if I can do anything for that patient, it's to help them reduce their PTSD, to help them access the way, the world around them the way that it is, and just for them, and the thing that I can do is to do no harm, to really work on making sure that I am right there with them and open and honest and collaborative with them, but them trusting me is not the purpose of this treatment. It's for them to start to trust themselves. And I just thought that was a really wonderful way of putting it, and and I've thought about that, and I've carried it with me in the many different patients that I've treated with DBT PE, and it does kind of ring true, and it actually takes, and I talk about it with them too, is that, trust is something, you may never trust me, and so that's okay. I don't need you to trust me, and instead I need you to show up and trust the treatment.
Yeah, Lara, that's so powerful. This is Jenni again. I totally agree with that from the patient side. I mean, something that helped me with just trust was just what you said, learning to trust the treatment at first. I mean, that was really my first step, and I actually have a biochemistry degree, so I kind of love reading research papers, and my friends, you guys know I like to read treatment manuals. But my therapist knew that, and so one of the first things he did with all the psychoeducation was actually give me a lot of research articles on how PE actually works. So it helped me start trusting the process. Well, if it works for these people in this study, maybe it can work for me. And another level of trust that was so critical for me was finding a group. I desperately needed a group of people who had PTSD and who were going through the treatment. Now, again, it needed to be a positive group, a group therapy, monitored, that was, kept safe. But for me, I personally don't think I could have recovered alone without ever meeting another person who had PTSD, because my group, like the groups we have at Insight and at ERC, that group was trust and safety to me as well. And then my therapist also got super creative. One thing that this is kind of like clothing, wardrobe therapy, but something that I did when I left the psych hospital, my therapist actually said, I want you to go to the store, and there was a Goodwill nearby, and I went to the store, and she said, I want you to buy a piece of safety clothing, something that can protect you when you're in the treatment center building. And I bought this pink hoodie, and I'll tell you what, that pink hoodie to me represented safety and trust, and it was just such an amazing thing that a pink hoodie could help me get through the treatment. But I wore that thing every single day, and I don't know if that you'd consider that a safety behavior, because I also wore it in exposures, but it helped me a lot, and it just in trusting the process. So there's a little wardrobe therapy for you.
That pink sweatshirt helped you move forward, and so that
Absolutely.
Safety is not a bad thing, and sometimes we need those to be protective in a healthy and effective manner.
Yeah.
It's not like you're still wearing it, Jenni.
What'd you say?
We're not all three in the same room. We're actually all in different states, so we can't see each other. That's why we're talking over each other. I just wanted to say that just with DBT and skills, those of you that don't know about DBT or haven't used it, skills really teach clients, really how to feel more capable and be more capable. So that, I think, just being able to use a skill gives them that sense of safety and internal motivation to continue to, move through the difficult emotions that they know are that they're dealing with now and they know will come during the treatment.
Yeah, and one other thing, and then I know we only have a few minutes, but it relates to the first question on this page too, is for me as a patient, establishing trust was I needed to believe that my therapist actually thought I had, quote, real trauma. And unfortunately, like Lara mentioned earlier, I did have previous clinicians many years ago who when I shared my trauma story, they completely dismissed it. And in fact, one even said, well, that you must have been abused when you were a child, because that's the only reason you would have put yourself in that situation as an adult. So that was real traumatic invalidation, and it happened several times. So one thing that helped me a lot with trusting my therapist much later on in this kind of treatment was when my therapist said to me, Jenni, what happened to you is enough. Nothing else had to happen. It's enough. And I will never forget those words. What happened to you is enough. And I'm so grateful, because that really helped with the traumatic invalidation that I'd experienced before. And it helped me build a lot of trust in that therapist as well as myself. But so, you guys, it looks like we're running out of time. Do you guys have any final comments, Andy or Lara? I don't think we have any more questions. Any closing words? We might want to share. Do you guys want to share if anybody wants to get trained?
Thank you, everyone, for joining us. And we do have the final part of this webinar, the third part of this webinar. We are going to go over troubleshooting. So those who want to kind of learn more about the details and those interfering behaviors, of the patient and of the therapist, and just kind of talk a little bit more about the ups and downs of, trauma treatment and how to stay the course. So looking more into the art of the trauma treatment, please come to the final third webinar, which all three of us will be together at that time. And I know that
January 10th as well.
Yes. January 10th.
And I just want to reiterate, January 10th, and I'm sure Alia will send you guys all the info, but thanks again for joining us, and thanks, Lara and Andy, for having me a part of this, and just, again, all of you guys. I don't know how often your patients thank you, but as a patient, I want to thank you because I would not be here today without all the dedication and the work that you guys do. And we also were told that we really need to remind you, this slide you're looking at now, you guys need to stay logged on until the presentation ends to take a survey and provide feedback, because that's actually how you get your CE credit, so that's really important. Make sure you do not log off and you stay logged on. And then you'll see our references here, but we're going to send you the slides as well as some other things that we talked about today, so you will be getting that from Alia. And thank you, Alia, for setting all this up. So,
and I just want to say, on behalf of Lara and I, Jenni, thank you so much for sharing your story with us, because you've made us so much better clinicians and empathic clinicians.
Oh, thank
you.
you.
Thank you, Jenni.
Great team. Well, you guys have a good evening, and please join us in the new year. We're giving you guys have great holidays, and we'll see you January 10th.
Happy holidays. Thank you.